Good morning, ladies and gentlemen, and welcome to this Euronews first Health Summit. I'm Jeremy Fleming-Jones, the Editor-in-Chief for EU News with Euronews. And we have today a variety of exciting health-related content for you. We're going to be having some interviews, some panels, and a few surprises thrown in. So without further ado, I'd like to introduce and welcome to the stage EU correspondent Shona Murray, who will be conducting and introducing the first interview. Hi, Shona.
Thanks, Jeremy. Now, thank you very much. And once again, thanks for joining us this morning. I'd like to welcome to the stage our first interview, Natalie Moll, Director General of the European Federation of Pharmaceutical Industries and Associations. You're very welcome, Natalie. Thank you so much. There's so much to talk about because we were chatting just there off stage, but I think it'll be great to actually introduce yourself to everyone here. And what I found fascinating is because you grew up in Morocco and your first love was biotech. And just tell us about that trajectory and how you started off there and then moved into pharmaceuticals.
Sure, thank you, Sean, and thank you very much for the invitation. It's great to be here. Indeed, yeah, I moved to Morocco the day after my 15th birthday, and I encountered the reality of challenges that a little bit we don't face when we're in Europe. So challenges about going to fetch your water or growing your crop when there's not much water around. And I realized that I wanted to find solutions and I wanted to understand how things work. And biology was great, but everything had been discovered, and I thought biotech. And when I suddenly started studying biotech, I understood, oh my God, this could really unlock some incredible solutions if you could just find the inspiration, test the ideas. And so I studied biotech in Scotland, which is quite far from Morocco. And then I came to Brussels when I realized I couldn't be a scientist because I wasn't smart enough. And I worked in the biotech industry for 21 years and I thought, I'm enabling the scientists who are smart enough to find the solutions, the challenges. And biotech is applied to plants, it's applied to industrial, and it's also applied to health. And that's how from biotech in health I've come to biotech in pharma, which is even wider. So really finding those solutions for the biggest challenges we have, and you've seen some of the advances we've created recently, even some cures, which is super exciting for people with Hep C, or if you look at AIDS, you know, when I was a little girl, AIDS was a death sentence. Yeah. And now it's a chronic disease. So I really think, you know, if we can channel science the right way, we will be able to solve some of the biggest challenges we have. So I love working in this area.
And that is a really important point about innovation, isn't it? Because that is key to, I suppose, what Mario Draghi discussed or highlighted in the Draghi report, the yawning chasm between European innovation and US and China, and how difficult it is for European pharmaceutical industry to translate innovation into something that is a commercial success or just a success in general. Mm-hmm. I mean, I suppose you found the report heartening in some way, but once again, it's only a report, it's how that's translated, right?
Yeah, it's an important picture at a really crucial moment in time. 20 years ago, the US invested 2 billion euros or dollars more than the EU in biotech and in science, and now it's 25 billion. So that's
huge.
1,000% more. The gap is 1,000% bigger. That's scary, and it also means that it's a trend over the last 20 years. So we've been on sort of free fall, well, not complete free fall, but pretty much, in terms of attracting capital, attracting investment, having the right ecosystem. So if as a region, and Draghi puts a massive lens on this, if as a region you want to be competitive, you want to have an ecosystem, you want to be resilient, you're going to have to stop the trend and reverse it. And to do that, you're going to have to put some serious measures in place. And I think those are the recommendations that he has in his report, which are really heartening. Now they have to be put into practice.
Yeah, but I mean, how has it gotten so bad, that trajectory, though? 25 billion euros in the difference in, 20 years, let's say. You know, that they've been able to innovate so strongly and we've receded. Mm-hmm. So what has actually gone wrong there?
I think you start with a disadvantage in Europe because you're 27 countries. So you are competing with the US, one country, China, one country, one policy, one decision-making, one language, one population, one set of investors. We're 27, which makes us incredibly rich and incredibly diverse, but of course also more complicated. and smaller and more fragmented. So you have a reality of an environment that is very different, and you have to decide together. So you want a policy, all 27 have to decide together, or 15 or whatever. And that means you are going to be slower. So you've got to do the things that you can do better. For example, we have a fantastic science ecosystem. We have incredible universities, but we have many. How can we cluster them together? And Draghi refers to that as well. How can you network? How can you have some centers of excellence? How can you avoid putting money everywhere and really making the best? I mean, if you look at the US, which again is one country you can't compare, they have 2 or 3 big clusters. And in those big clusters, if you're a company, you can attract people to come and work there, because even if the companies go bust, they'll go to the neighbor. When you sit down and have coffee, you meet the best entrepreneurs and scientists, because they all live there. And in Europe, at the moment, we don't have that. We have many little ones in different languages, different places, and we really need to think, capitalize, make it bigger, make it more, make this ecosystem more comparable in size and in attractivity to the ones, certainly in the US. China is another model. That's 20 years of 5-year policies focused on biotech. Every 5 years, biotech, biotech, biotech. Yeah. If you do that, then you get the 400% increase in number of SMEs that they've just had.
Incredible. I mean, the thing is, what you've pointed out there is all true, but we sort of know that. We know there were 27 different countries with fragmented access to pharmaceutical and medical care and so on. Do you think that part of it is that we've rested on our laurels and just not done anything about it?
I think there's a misconception that because we have great science and because we have great universities and because we found the COVID vaccine, we're doing great in Europe. And we kind of take the eye off the fact that all the new developments like advanced therapies, so those cell and gene therapies, the ones that could probably give cures, there are 3 times more clinical trials, so 3 times more research in China than in the EU, twice as many in the US than in the EU. So it's true, we have our research and we have our manufacturing that we've always had, but the new stuff is being done elsewhere. And I think that's difficult to see because, you know, when you're looking, it all looks fine unless you look outside. And when you look outside, then it's a different picture.
And then one of the points that you'd made when you received the Draghi report was that you're thankful that he was encouraging the Commission and the EU to engage with stakeholders, but particularly industry stakeholders, to discuss this sort of regulatory system that often it's impractical and that you get no say, and then before you know it, it's in place and you have to just deal with it. So are you confident or in any way, you know, believing that the EU will engage with the industry and has, you know, recognized that this is a really big issue?
Well, I've seen many parts of the Draghi report in the mission letters.
Yeah.
So that's true, a very clear indication that the Draghi report is not just a report that's been put in a drawer, but is something that has really been looked at and then hopefully brought to life in the mission letters, which in the next 5 years have to be implemented. And it's been in different bits, right? So not just in pharma, but those stakeholder dialogues are so important. For us right now, we're revising the whole pharmaceutical legislation for the first time in 20 years. So this is, hopefully you don't revise it every 5 years, which means we need to get it right for the next 20 years. So you would have to make sure that the people who have to then use the legislation, industry, because it's regulating our products, can use it and can make good use of it. The other thing you have to make sure of is that it is as attractive and competitive and fast as other regions. At the moment, it takes twice as long to approve products in Europe than in the US. Twice as long.
Yeah.
For the reasons that I mentioned, 27 countries. But still, you're competing with, you're already 27 countries. So you need to get the stuff that is European, like the legislation, like the health technology assessment. Anything that is European, you have to get really right so that you can be attractive to other parts of the world who look and say, oh my God, 27 countries, that's complicated. So the European stuff, you have to get really squeaky clean, super attractive, super forward-looking and future-proof to be competitive.
And one of the things we hear from Stella Kyriakides later, the EU Commissioner for Health, was you know, the idea of equity amongst those member states. And again, you talked about 27 countries. How do you think that can be improved? Because I know the EU did come up with that new pharmaceutical proposals in 2023 about trying to encourage pharmaceutical industry to get to get medicines to all 27. I mean, but they're saying things like that they give extra data protection to companies that do manage to do it. I mean, how feasible is all of that?
So first of all, I think it's important to notice that they don't give extra. First, they take away from what we have today, which is 8 years. So they go down to 6, and if you do a series of things, you'll get to 8. So it's a bit different.
Right, yeah. So you can explain that again. Yeah, they take away time.
Yeah, so today it's the regulatory data protection. So there's protection you have on your data is 8 years, which is actually one of the most competitive things we have compared to the US. So the US don't have that long. So this is something that is quite attractive in our world. So for biologics, they have 12, but for smaller molecules, they have 5. So good for Europe.
Okay.
But here the idea is we reduce it to 6. And if you are on all markets within 2 years, you will get the 2 years that you had before. Now, the problem with that equation is that it's not up to us to decide whether we can be on a market. So with a glass, I sell it wherever I want. With a medicine, I have to come to an agreement with every single country on a price, and that country needs to be able to accept my product. So for example, if you have one of those therapies I was talking about, the cell and gene therapies, if the country doesn't have the hospitals or the doctors or the training or the infrastructure to implement that treatment, it can't say yes. So it first has to create the whole, either the training of the doctors or the whole infrastructure to do that. So even if there was a price, the country couldn't accept it. Then you have countries that are quite exceptional who want the price to be set in 5 other countries before they decide their price. So think about that logic, and how can I be sure that within 2 years of my approval, I'll get it on the market if it doesn't even depend on me? It's impossible. So basically you're saying it's 6 years to an investor. So an investor's looking and going, oh, where's my IP protection?
You can't guarantee the other two, of course.
You can't so there are better ways. I mean, equity is super important. And the fact that our products don't reach patients is in nobody's interest. You would never want to sell somebody that nobody's buying, right? That's not the point. If you're making a medicine, the whole point is that somebody gets to use it. And so what we've called on is that dialogue that you were referring to before on access. Because again, because it's not just our responsibility as an industry, not even just the payers, because you need the doctors and the hospitals and everybody to be up to date, can we have like a dialogue on how can we improve access? Because it's not acceptable that some patients in some countries have to wait this long and others. So, but everybody has to play that part in fixing that puzzle. And it's not with European legislation that you're going to fix a national access problem. So at the same time as the revision, which is fantastic, because you updating a regulatory system after 20 years, you know, we're going to be attractive, we're going to be fast. Can we have the same attention given to access, but in a way that's going to work with that stakeholder dialogue, with the member states, with the hospitals, with the doctors, with the patients, with the industry? For us, that is the way forward. And we've put some stuff in place. We've, made commitments to file for pricing in all member states within 2 years. And we're measuring that every 6 months. So we're not just saying, we're doing and checking. And we've also proposed a framework for something called equity tiered pricing, which is delivering products on the price that a country can pay for. But because we have a single market, we have to still work with stakeholders to make that happen, because if you sell in one country, it might end up in another right now and not reach the patients you had originally. So, we've done our little bit, but it's not going to solve access. And again, real attention in this commission to access. I think all stakeholders, most of them sitting in the room, would really like to do that together.
So it's really a lot of it is down to the member states to create an infrastructure where their citizens can have access to important medicines. And often that just isn't the case for some governments. They're not prioritising certain aspects of access to pharmaceuticals. It's not key to them.
I was in one of the Baltics a few years ago, and I asked how much of your GDP is on health, and they said 2%. Everything else is on defense.
Yes,
and
exactly now.
You can't blame them, and that was before Ukraine.
Right, okay.
So you can imagine what it is. So, that's the reality of Europe. And so then for example, there are some European funds, some structural funds, there are some European tools that you can use to help member states very pointedly improve their healthcare systems. And after COVID, the healthcare system struggled a lot, right? We spent a lot of money for COVID-related things, but we diverted some money from other areas. Not to mention the health workforce suffered a lot.
Of course,
so we're lacking. So there are some tools that European level tools that we can used to help. That's the strength of Europe. You don't have that in other parts. You know, if the US is having a hard time, the US is having a hard time. If a European member state is having a hard time, there are some really good European funding mechanisms that can help. But you'd have to really focus on health security. You'd have to say, okay, it's not just about economic security, it's about health security. Those funds have to go to this and strengthen healthcare systems. But, you know, I think in the new mandate, we have those opportunities. And we have that focus on health security, economic security. So I'm really hopeful, but maybe I've been here too long.
Do you think there's more of an appetite, though, at least amongst the member states, to allow the EU have more competence in the area of health because of the trauma of the COVID crisis, and then realizing that we actually have to work in a joint capacity?
You know, I think what COVID taught us at the beginning was quite scary, that you can't count on solidarity. And this is something one of my members said very honestly in a discussion the other day on critical medicines. The first thing everybody did was shut their borders immediately, and not just for one day. And so I remember we used to have calls every Friday morning to discuss among the Commission and all the stakeholders what needed to be done. The first thing we needed were green lanes so that we could get the trucks from one country into the other, but also the workers. So you know, I think COVID taught us a lot, but the proof would have to be in, if we ever have that situation again, how would we behave? And there's some great stuff like the Critical Medicines Alliance. There's real work that came from that trauma, as you say, that's like, so next time let's not be caught like that. The other good part, I think, is that we had the technology. We had the ecosystem, we had the science that gave us the vaccine. If we don't look after that ecosystem, if we don't take the measures in Draghi and others, next time we might not be so lucky. And the US took a long time to start exporting vaccines. We exported from day one.
Yeah, and we've heard the warning signs from Macron, who says our Europe is mortal, it can die, and from Draghi as well, saying that we, in fear of dying a slow death. I mean, they're pretty loud warning signs. Another warning sign, sorry to have a Wednesday morning, but is the rise of antimicrobial resistance. That's another issue that, I mean, it appears to be worsening. I mean, we talked about this. I remember tried COVID, it was a problem, but it doesn't seem to be getting any better. What is your own view of how this can be tackled?
I think that is really, it's not just the deaths from antimicrobial resistance, which I think are 35 million a year, and it's costing billions to the healthcare systems. The problem with antimicrobial resistance is that it will make any modern medicine useless, because you will go for a chemo and you'll get an infection and you might die from the infection. You'll go to have a baby and you'll get an infection. You'll cut your foot and you'll get an infection. So it's going to make our modern medicine tools that we're so excited about completely irrelevant. And it's going to send us back to the dark ages. So how do you fix that? There are different things that you need, right? So it's a product that you shouldn't sell much of, and you certainly shouldn't use. So the market logic of this product doesn't work. So you have to find another way. You have to incentivize the science, which is super difficult because it's actually an agent that has to kill lots of things, but not the person. So think about that scientifically. It's super complicated to create. And then you have to have it, so on the push side of science, you have to create. And I think we're good at that. I mean, in Europe, we're good at push incentives. We're good at creating scientific environments. In fact, we have the first new antibiotic was approved a few months ago in a public-private partnership between the Commission and Pfizer. That's impressive.
Yeah.
The first global new antibiotic since the 80s. Amazing, great. But then how do you keep it alive since you can't sell it? And another good news, I would say, in the Commission text that you were referring to, the one of 2023, the regulatory review, there's an idea of having a pull incentive, so a market incentive that would make it attractive for a company to go through all the clinical trials and et cetera to get it to the market. It's called a transferable exclusivity voucher. So basically, if I'm doing the antibiotic, I get to use the exclusivity that doesn't matter on my antibiotic because I don't want to sell it onto another product or to sell it to another company. It has to be proportionate, it has a lot of safeguards, but it makes suddenly that work that is very complicated, expensive, and unpredictable, valuable because I can put it on a product that I know I can sell.
Yeah.
So I think that's really smart. We'd be the first region in the world to have a pull incentive. Quite
We
nice.
finally
Again,
be doing something new.
yeah, with a European thing. You know, that's famous.
Absolutely.
Looking good as Europeans. So I think that's a real win. The Commission proposed it, the Parliament kept it in, so now it's the Council discussing. But again, you know, that would be a piece of legislation that puts us back on the map, regulatory-wise, AMR-wise. I think it's a win-win if they can just avoid using incentives to regulate market access, which is not going to work. We talked about that.
Just one final question I wanted to ask you about. It's not related to that, but it's about the issue of disinformation, which we're all suffering from one way or another. And when you hear things about vaccines, there's a lot of disinformation around vaccine use throughout COVID, but also the impact that they may have now on childhood vaccines, and you see that the trends are reducing. Also, from a pharmaceutical perspective, throughout COVID, we heard about the use of things like ivermectin, you know, parasitical killer for basically treating COVID and anything else. How does that, or do you see that impact in the industry, but I suppose not just the industry, but patients themselves?
Yeah, so I think you said it, and the biggest impact is on patients themselves. And in a world where everybody has access to internet, and as soon as you feel something, you go and check and decide, you know your diagnosis, it's very difficult to explain what the realities are and how important things like basic things like you get a therapy, adhere to the therapy, stick with the therapy. If you don't stick to the therapy, it might not work anymore. The other day we had a professor come and speak to our staff. We had a staff meeting, and he explained that vaccination from influenza, as well as COVID, reduces heart attacks by 60%. This is something I had no idea of. And you think the misinformation that's out there, also that, for example, the famous statement about 30 or 40 years ago that the mumps vaccine gave autism.
Yes.
That professor retracted his study.
But we don't hear that.
But you don't hear that.
Yeah.
So you have what remains is always the bad news.
It's lingering,
and the incredibly important news of, I'm so glad I take my vaccine every year against influenza because it will reduce my possibility of having heart attack. That doesn't come out. So we need to, I think the health community, and I don't mean to point fingers here, but we need to make an extra effort, together with you as journalists. I think that's really important, to just spread the right information to make sure patients are protected as much as possible.
Brilliant. Well, listen, Natalie Moll, thank you very much for joining us.
My pleasure.
Really appreciate it.
Thank you very much. Thanks. Thanks, Sean. Thank you.
And I'd like to re-welcome Jeremy Fleming-Jones back to the stage for the rest of the Health Summit. Thank you very much. That's right, our new interview, the Europe Conversation, which will be weekly every Thursday. So we hope to stay tuned for all the best interviews on all things Europe and transatlantic relations and anything to do with Europe. But that'll be on Thursday evenings from next week onwards. So thank you. Thank you.
Make some medicines critical and others not? Why should some medicines be critical? That's the subject of our next panel, and we have three highly qualified people ready to take on the issue. So I'd like to welcome now up onto the stage Olivier Girard, who is the head of unit for medical countermeasures with the Health Emergency Preparedness and Response Authority of the European Commission.
But it's just that I felt...
Gloria Hequier, who is an advisor in the cabinet of the Belgian Deputy Prime Minister. And finally, an associate director with think tank, the European Policy Centre, Elizabeth Kuiper. Welcome, all of you. So maybe, Elizabeth, if I could just start with you. Why is there an issue about critical medicines? Where did this issue of critical medicines come from in the last 5 years?
Well, thank you, Jeremy. Good morning, everyone. I think that's a very pertinent question, because already before the pandemic, we knew that there were shortages. And of course, that's a major public health concern. It's a concern for patients. But I think the pandemic and also the current geopolitical situation put this question in a very different context again. Because we did not only realize as Europeans how critical medicines are, but also how much they're of geopolitical importance. Because we realized at some point when India closed its borders that indeed we in Europe suffered because of the fact that we were dependent with paracetamol, ibuprofen. I think we all know the example of the masks coming from China. At some point, the US closed its borders, which was very detrimental for the EU when it came to vaccines development. So I think that made us realize that we're not just speaking about public health concerns, but also about economic security, if you wish, and the need to address unwanted dependencies. And I think, therefore, it's so important that ever since the European Commission is working on economic security, that there is an understanding that health is not just a sector where you have perhaps some competences at EU level, but where most of the actions are taking place at member state level. And I think that is very important. So in that respect, I'm also very much looking forward to the next European Commission, where I think that we will see all of these actions to do with critical medicines, but I think more importantly, with the critical importance of the healthcare sector, more in coherence and more in a holistic way.
So the pandemic put health and healthcare right at the forefront of the European Commission concerns. But traditionally, health is not really a fundamental competence of the European Commission under the treaties. Is that right?
Well, there always have been competences. I think for people like probably most of the audience working on health, I think we all know that over time health has really developed at the EU level, the cross-border healthcare directive, and more also competences to do with global health. But indeed, I think the importance of health being vital for our economies as well, because we have seen it with the health workforce in the pandemic. If you're ill and you can't work, that has an economic impact as well. And again, I think especially when you take into account also the economic analysis of the Letta and the Draghi reports that already were mentioned this morning, the pharmaceutical sector is a major sector for Europe as well. So again, I think health has always been important, but in a much more limited way. And I think that recognition, and I think it was the Spanish presidency that came up with a report by saying that together with food and energy, health is a strategic sector. And I think that word strategic was indeed not something that we had witnessed at European level before.
Right, thank you, Elizabeth. Gloria, maybe we could come now to you. You were working for the Belgian health minister, I think, at the time of the pandemic, and became heavily involved in the notion of creating a strategy for critical medicines. Could you tell us a little bit about how that came about and what you did with it?
Well, actually, I started with the health minister after the pandemic. Before the pandemic, I was working on international trade, and we were very much following these pharmaceutical supply chains, and indeed the disruptions were very great, and it showed the importance of working on your value chain if you want to attack or tackle problems like these. Now, I was hired by the minister a year before the presidency, and we were immediately confronted with these medicine shortages. In Belgium, we had a very grave shortage of thrombolytics because a supplier had to quit production. He had to quit production because of quality issues. And at a certain point, we were quite scared that patients would die because we could not find thrombolytics on the international markets anymore.
Perhaps you could just explain what do thrombolytics do for patients?
Well, I am not a doctor, but a thrombolytic, basically when you get a heart attack or you have a blood clot or whatever, you take a thrombolytic, and it must be administered within 4 hours after your thrombosis, let's say. So it's a critical medicine. And so that's when I started looking what is happening at the EU level. And of course, at that moment, the Commission was working on the pharmaceutical legislation, but it was quite clear that the pharmaceutical legislation is not an industrial strategy. And even though at the EU level there had already been a structured dialogue in which it was quite clear that the market for generics was consolidated, that often we only have 1 or 2 producers left, and then if a producer falls away, you really have a problem. So even though that was quite clear, there was no industrial strategy in place, and that's what we did with the Belgian presidency. So we worked quite well with Spain. Spain at that time was working on the Granada Declaration, which was all about open strategic autonomy. So we kind of used our trio presidency to prepare this Critical Medicines Alliance and this Critical Medicines Act, and to unite the member states. And I think we were quite successful. We wrote a paper with a few proposals, with 3 proposals: a solidarity mechanism, supply chain mapping, and then last, a Critical Medicines Act. And I think they're all in place now. We had a lot of support.
Thank you for that. And Olivier, you are responsible, or one of the people responsible within the Commission for implementing the fruits of, as it were, of the Belgian proposal. Could you just perhaps run us through how that works within the institution? You're obviously the head of unit for medical countermeasures with this rather interesting sounding division of the Commission. Could you tell us a little bit more about HERA and what you're doing there?
Sure. Thank you, Jeremy. So I'm working for HERA. HERA is a new authority within the Commission, and it is the result of the lessons of COVID-19. It's about health emergency, preparedness as response. And what is interesting in the mandate of HERA is that it has this preparedness mandate, but at the same time, it has also an industrial mandate. Because we know that if we want to be better prepared for crisis, we need to speak with industry, we need to put in place partnership, we need to support innovation and research, so we need to be equipped. And when it came to connecting the dots, and thanks to the Belgian presidency, there was a realization that we had developed an experience during COVID-19 of making member states working together, which would be relevant to develop this industrial policy. But it is true that we started from scratch. But what is interesting is that we had some good precedents with the concept of industrial alliances, because the Commission was able to develop such alliances for big industrial challenges, such as batteries or semiconductors, like critical raw materials, and it proved quite successful, because you cannot do industrial policy on your own. You need to have everybody around the table. It's about good use of public money. It's about setting priorities. It's about identifying problems. And for that, we need everyone. And the good news is that the alliance is a very inclusive mechanism. It is successful because it's only 5 months old, but we already have 285 members coming from Europe, coming from third countries, coming from member states, coming from patient organizations, coming from health professionals. And work is progressing quite fast, because I think everybody has understood that the alliance comes at the right time. The new Commission is coming, you need to influence the process, and you need to be on time when the new Commission is going to start to come with your recommendations. So that's the plan. That's the plan for the alliance, to come with a strategic report, beginning of 25, and this is when the new Commission is going to start the work. And of course, extra motivation for the participants. President von der Leyen has confirmed that the new Commission will come with a Critical Medicines Act. So the timing is perfect, but it's a lot of work. And we are very thankful to the participants for all their commitment. And we will, of course, need to be ready for the beginning of 25.
So in terms of the critical medicine strategy, there is the alliance which was launched, as you said, 5 months ago. Where is the legislative potential for this to go, do you think, in terms of timing and what sort of rules might be expected?
So the good news, and of course I cannot speak for the next Commission. We are in the von der Leyen 1 Commission, and I cannot speak for the von der Leyen 2 Commission. But as far as the von der Leyen 1 Commission is concerned, I think there is the recognition that you need to have a toolbox, an EU toolbox for industrial policy. You need to develop this toolbox, like you have done in other areas for critical raw materials, for chips, for batteries. And you need to have an enabling framework, something that is going to help the member state, that's going to help the industry to actually look and identify the priorities and tackle them and address them. So there is potential for legislation. The good news also is that the president has decided that it would not be part of the 100 days, because of course it's a complex area, it's a highly regulated area, so we need to give it time, we need to follow better regulation, and we need to consult. So that's really something that is going to keep us busy, I believe, in the course of 25.
Right. Thank you, Olivier. I want to come back now to Elizabeth, but I wanted to invite you in the audience, if you have any questions for our panelists, please don't hesitate to indicate, and I'll try and come to you before the end of our panel, okay? Elizabeth, this is a critical medicine strategy. There is an alliance. As we've heard, there could be some rules coming in due course as well. But the whole notion of critical medicine sits within an industrial framework, the need to boost production. What other rules, what other measures that the Commission might have in store or that are currently being considered do you think impact on critical medicines? Because we've already heard from Natalie about the pharmaceutical rules, which are, I think, up for reconsideration in the early part of next year. Could you tell us a little bit about where critical medicines fit within an ecosystem, if you like?
I think, first of all, it's important to acknowledge that indeed there is now much more attention for the fact that we need to cover the nexus between industrial strategy and pharmaceutical strategy. Because for the work that I'm doing for the European Policy Center, I've been saying for years that that was missing. And I think that's even what was missing from the start of the negotiations on the pharmaceutical framework. I think that was, and perhaps still is, seen mainly as a tool to address access to medicines. And as important as it is, we also, from an EU perspective, need to cover the industrial infrastructure, because after all, only if you have the infrastructure in place, then you can speak about access to medicines. And therefore, it's so important to indeed put the topic of critical medicines in the context of economic security. Because in the previous interview, the word trauma was used. And of course, it's important to recognize that probably the initial actions on critical medicines had to do with a trauma, that we realized that indeed, as EU citizens, we were relying on other parts of the world. But I think at the same time, and I think also there the messages of Letta and Draghi come in, we need to seize this as an opportunity. So we also need to speak about the value creation of the pharmaceutical sector for the EU, and the value that this industry brings for the EU. And therefore, I think if you then ask that question about what will happen in the years to come, I mean, we are still under von der Leyen 1, yes, but luckily we have all these mission letters with a lot of actions, because we will have the so-called Biotech Act, we will have a life sciences strategy, there are still the ongoing negotiations on the pharmaceutical framework. I think also very importantly, the vice president, who's going to be responsible for the just transition, is very explicitly tasked in her mission letter to deal with the nexus between the environment and health. So in that respect, what I hope, and perhaps Olivier can come into that later, that we also take into account the environmental aspect. So if we speak about manufacturing and advanced manufacturing, let's also then make it green manufacturing. Because I think what sometimes is missing, and I think that should come with a notion of economic security, is foresight. That again, we don't only start from that trauma and try to address an immediate concern, but that we really take into account the broader context. And I think with the current setup of the Commission, at least on paper, it looks like all these intersections between the different areas will be covered better than in the past.
Right. Maybe moving back to you, Gloria. I mean, I understand that state aid and competition issues can also impact on pharmaceutical and critical medicines. Could you maybe explain a little bit about how that's the case?
Yeah, and I will also dip into the issue of greening manufacturing. There was an interesting case in Kundl in Austria with a production plant of antibiotics. Now, you have to know that the world is highly, highly dependent on China for antibiotics. I think 80 to 90% of the global supply of APIs comes from China, but we had one production plant still in Europe with end-to-end manufacturing for antibiotics. Now, during the energy crisis, this production plant was almost going bankrupt because the energy prices were increasing so rapidly. And at the same time, antibiotics is extremely energy intensive. It's very energy intensive to produce. So the Austrian government managed to make a deal with the producer to green the manufacturing site, to make it less resource intensive. Now, it took years for the Commission to approve this greening plan because there was a great deal of state aid involved. It was a public-private partnership, and there are no good state aid rules to approve this type of partnership because antibiotics is an old product, and even though you might innovate a little bit in the production process, state aid rules generally are tailored towards new research and development, first industrial deployment, but not the type of upgrading of production of critical medicines. And I think this also for us was a brilliant case to illustrate that we need a legal framework for critical medicines that is tailored to the needs of this industry, because you cannot compare it to an innovative industry. A second part, I think, which is really important is that you need to create a sustainable market for these medicines, because indeed in Europe we have rules on wastewater management, we have rules on pollution in general, and it's a polluting industry, right? And so if you want European production, and if you want this production to be greener and healthier, then you also need to reward the producers that produce in Europe in a greener and healthier manner than they would in China or India. And I think there we need to look at the public procurement rules, right? And really reward green and European production. And I also think that maybe the time is ripe for member states to start discussing on pricing a little bit. And with sustainable pricing, I do not only mean increasing the prices, that's a part of it where necessary and based on evidence, of course. So we would need a certain degree of transparency, but it's also about making sure that there is some convergence between European prices so that the markets that price higher do not vacuum the poorer markets where they pay maybe a little bit less for their medicine. So even there, I think the alliance would be a great vehicle to start these types of discussions.
Interesting to hear how state aid and sustainability are obviously other policy areas which are impacting heavily on critical medicines. Maybe just going back to those pharma rules, Elizabeth, I mean, one of the issues which has caught the eye and gained a lot of attention is the speed and the amount of time that pharmaceutical companies will be given protection for their products in the market. I think at the moment, the status quo is that they have about 8 years, and the proposals would see that drop depending on whether it's the Commission proposal by more than a year and a half, but the Parliament, I think, is seeking to edge it up a bit more. Why does that issue matter, do you think, and do you think that could have an impact on critical medicines?
Well, I think the reason why that really matters is that these incentives for innovation will inform decisions of pharmaceutical companies to either remain in the EU or invest elsewhere. And I think, therefore, it's such a critical balance, if you wish, to look at the framework and ensure it's going to be future-proof, because the current framework is old. I mean, it's from the 2000s, so the state of technology was very, very different. I mean, if you think about enabling technologies like AI, we didn't have that in the 2000s. So there's an absolute need to adapt the framework, but I think we need to strike a balance, right? And I think the current discussion about the EU's place in the world shows that we cannot deal with it in isolation. So the decisions that we're going to make in the EU about these rules will inform future decisions, and therefore it's so important to think about what Draghi mentions about competition. So for patients' access, indeed we need to see and have a longer term vision, because only if we have the right infrastructure and the right incentives, then indeed we will have the continued engagement at that level. And therefore this nexus between pharmaceutical strategy and industrial strategy is so important.
Right. Olivier, let's come back to you. We've just heard a lot about the different policy areas which obviously don't belong in HERA's backyard. But I wondered if you could just tell us a little bit about where the alliance is at. I mean, what has it actually achieved so far? And how do you actually define what is a critical medicine? I mean, has there been any really clear image of that coming from what's happened so far?
So in terms of definition, I think we are very lucky because we have a common EU framework for critical medicines. Our colleagues at the EMA have defined a first list of 216 substances at the end of 2023. And they're working now, of course, on expanding the list. And it's a very good frame of reference for us. And it's a medical advice. So this is not an industrial list. It's a medical list, and it's about two criteria. First of all, the fact that their availability or non-availability will have consequences on human health, direct consequences. And the second criteria is that it is, how should I say, it has no substitute. So this is the second criteria. And on this basis, we can work. And that's our starting point. And when it comes to the alliance, I think that we are adopting, the alliance is adopting, I would say, a double approach in the spirit of open strategic autonomy. So we have working groups. We have one working group working on the strengthening of manufacturing in the EU, about what Elizabeth and Gloria just said, investment, innovation, research, how we can support this manufacturing base, because as Elizabeth said, and Nathalie also, it is this manufacturing base that saved us at the time of COVID-19. So we need to strengthen it. But at the same time, we live in a global world. Our companies are exporting. They are relying on international value chains. So it's very important that we build partnerships with third countries, that we look for diversification, that we look for new countries with whom we can work in the spirit of open strategic autonomy. So this is really the work that is going on at the moment at technical level, and that will be reflected in the strategic report that the Alliance will come up with in beginning of 25.
So this list of medicines comes from the EMA. I mean, if I am a pharmaceutical company or a medical body that thinks that a specific medicine should be on that list but is not, what is the process by which the decisions are made by the EMA? Can you cast any light on that?
Well, it is not our responsibility, it's indeed the responsibility of the EMA, and the EMA as a dedicated body with all member states involved to come forward with a proposal, and EMA decides whether or not it should be on the list. But it's an evolutive process, it's an open-ended process, and what we have seen at the end of 23, the first chapter, and it's probably going to expand to several hundred medicines.
Right, okay. We're obviously within the legislative cycle at a very important crossover, transfer period. This whole strategy has been launched in the final year of a Commission's mandate. We're expecting a changing of the guard, obviously. We have some commissioners designate, Oliver Verhely for health, Hadja Labib for preparedness, and others who, as you have said, will touch on critical medicines. Perhaps, Olivier, I wouldn't expect you to comment on how well you expect any of those players to perform, but could you perhaps explain a little bit from the mission letters how you see those responsibilities for critical medicines being divided among the new commissioners designate?
I think that the topic will attract a lot of attention because, of course, as you mentioned it very well, the development of an industrial policy for critical medicines involves lots of departments from the Commission. Gloria mentioned DG Competition. You mentioned DG Environment. Of course, there's DG Trade. So at the end, it will be a collegial work. So potentially, you will have numerous commissioners and executive vice presidents who are going to be involved. The way we are doing it at the moment is that we have a core group with our colleagues from DG Santé, colleagues from the Secretariat General, from DG Grow, so those in charge of health, industrial policy, general coordination, who are meeting every single week to agree, decide, see how we can support the work of the alliance and how we can take things forward. So we're really preparing the ground at our level for the next commission. And I think that's a topic that should attract quite a lot of attention in the parliament during the hearings.
Right. And just maybe to coming back to you, I mean, your Belgian former foreign minister is obviously going to be in preparedness, but I think that her mission letter only relates to stockpiling. She's been given some kind of remit for stockpiling. So that preparedness commissioner is not necessarily going to be one who is so directly concerned with critical medicines, or
I don't know for sure, honestly, but it would seem logical to me that indeed her main responsibility would be CBRN stockpiling, even though I have to admit...
Perhaps you could quickly just explain what that is.
Okay. These are typically the stockpiles that you would need when there's, for instance, a nuclear threat or a war. So these are really crisis stockpiles. Now, of course, there is some kind of overlap with critical medicines, because the medicines that you would need during a nuclear threat, for instance, or during a war, often are critical medicines. So there is some overlap, and I would expect her to be interested in the work of the alliance. But in the first place, I would argue that this is also really about the basic medicines that keep your health systems going, right? And so I would think, therefore, that it's mainly a health matter, even though there is an overlap.
Okay. We're coming now into the last stretch of the panel, so I would like to invite anyone in the audience who has any questions to indicate now, so that we can see before.
Hi, thank you very much for your super interesting remarks. My question would be really related to more focus on medical devices, because I understand these are also becoming in the remit of the Critical Medicines Act. Of course, the situation here is different. The supply chains are often a little bit more complicated and affected by different political issues, such as shortages of chips, for example. So what do you think the challenges will be there, and how the Critical Medicines Act can overcome these? Thank you.
Okay. Thanks very much. Well, quickly, maybe Olivier.
Sure. Thanks for asking. Indeed, what was interesting for us in the mission letter is that the scope of the Critical Medicines Act has been expanded to medical devices. So, of course, it's an important development. So far, we had focused on critical medicines. So this is something we need to take into account. And as you said, medical devices are quite specific, even if you could argue that they are also part of the supply chains for critical medicines. So that's a new development, and we are working very closely with the colleagues from DG Santé to make sure that indeed, when we come forward with a proposal on the Critical Medicines Act, medical devices would be fully part of it.
And perhaps, if I may, I think indeed medical devices is a very important question, because I think we have now been speaking a lot about the unwanted dependencies that are known, that we know that will pose problems. Because I think medical devices may actually be an area where we have a lot of unknown dependencies. If you think about wearables and the fact that a lot of people use these with a lot of data coming in, if we speak about the influence of China and Russia and also disinformation, etc., how will that work out? So I think in that respect, I think these are issues that we also need to capture going forward.
Elizabeth, I'd like to stick with you because we heard from Olivier a little bit on the division of responsibilities in the next commission. But I wanted to ask you the same question. I mean, how do you see, having read the mission letters to the various commissioners, how do you see this issue being distributed? Do you think it will be efficient? And also, how do you expect the Parliament to interact on this issue in the next mandate?
Well, your previous question about Labib, the Belgian commissioner who's going to be responsible for preparedness, made me think that it's really important to get the balance right. I think it's all for me about the definition of critical, because for a patient, everything is critical. Because if you're in the pharmacy, you can't get your medicines, that is critical. However, I think we should not make the mistake to then think that, especially also in light of the demographic transition, where also a lot of patients will become chronic patients with, again, more demand for medicines. And we cannot, think about reshoring all of these to the EU because we don't have the capacity, it will have a massive economic impact. So in that respect, I think getting that balance right between indeed ensuring a critical mass for these products that really are at stake and are at risk, but also indeed creating that value and innovation potential. So what I hope, and again, where we have seen in the past that sometimes in the parliaments, the commissions really focus on, let's say, their missions and their commissioners, sometimes have that more narrow approach. So what I do hope that also in the coordination of the question to the different commissioners and vice president, the parliament itself realizes that if the commission takes a more holistic approach, the parliament needs to do the same.
Okay. Thank you. Well, we're drawing to an end of the discussion now, so I thought I'd just invite you to close by giving your hopes for, we're, as I said, at the end of one mandate, but if we look forward to the end of the next mandate, what would you hope by the end of the next mandate will have been achieved on the critical medicine strategy, and where should we be in an ideal world, Olivier? If we could start with you.
I would hope two things. I mean, first of all, as explained, this work is complex. We need to work with the member states. We need to work with the health authorities. We need to work with industry. But I think we have a common goal, which is the development of a culture of preparedness, a culture of security of supply, and the recognition that critical medicines are a strategic sector as important as energy, as water, and that all the tools that the EU has at its disposal and this ability to make people work together can be fully dedicated to this goal. So that's really my hope for the end of the mandate.
Okay. Very quickly, over to you, Elizabeth.
Well, indeed, I think the importance of health and health security in that broader context of economic security, and that the messages we got from Letta and Draghi are not just only important for the Common Market Union or the energy sector, but as important for health and the pharmaceutical sector being an enabling sector for other sectors. I think if that sticks, then I think we have achieved a lot.
Gloria, last word for you.
Yeah, I hope that this concept of a European health union becomes mature, and so that health will be an important topic on the Commission agenda in any case. And then secondly, I hope for some bravery, because the topics that we are touching upon with critical medicines often are taboo, such as reform of the state aid rules, so that it's not only about innovation, openly discussing prices, talking public procurement. There are a lot of taboos in this topic, and I hope that we have the bravery to overcome those.
Well, ladies and gentlemen, thank you very much. If you could thank the audience.
Thank you. Thanks
thank
a lot.
The panel. So we're now, ladies and gentlemen, going to welcome on stage Leo Exter. He is from Hack Belgium Labs. And Leo has the somewhat interesting title of Chief Energizer. So he's going to be adding a little bit of interest other than interviews and panels to the proceedings now. So as soon as Leo comes on stage, we can ask him. Hi, Leo. Nice to meet you.
Hi. Morning, guys.
Perhaps before you start, you can, on your interactive session with the audience, you could just tell us what is a chief energizer?
I do this. I talk to the public. I get them energized a little bit. So round of applause just for the sake of it. There we go. Excellent public.
Great. Well, I'll leave them in your hands.
Thanks very much. Well, I do a little bit more than that, actually. So I organize hackathons. Who's taking part in a hackathon? Show of hands. One. One hand for the entire room. God. Goodness gracious. All right. Hackathons are essentially innovation events, and I've been doing them for the past 14 years. And I've learned 3 things over these 14 years. I've learned a lot more, but I'm not going to talk about them today. So the first thing is, people love to talk to one another. Surprise, right? Even to strangers, especially to strangers. Second, people love solving problems. And on occasion, they can actually solve them very, very effectively. And there was a third thing. Yes, that any problem can be solved, assuming you move the goalposts a little bit. Right? I see a lot of disbelief in the room, so what I'm actually going to do is I'll show you that this all can be done. So for the next 30 seconds, I'd like for you to close your eyes, and think about a problem you would love to see solved in events like this in the future, a problem related to the topic of today that you really want to work on, that you really want to solve. 30 seconds, your time starts now. Excellent. Now the next part is going to be a bit more messy. So now I need you to stand up and find a random stranger, because I'm sure you're sitting here next to people you already know, your colleagues. So find a random stranger, take 30 seconds to introduce yourself, what you do, your name, first name, nobody cares about your last name, and the problem you want solved. And then you have 30 seconds to listen to their problem. Right? Your time starts now. Meet a random stranger. They can be next to you, they can be behind you or ahead of you. Go, go, go. You can stand up and move around, that's allowed. Okay, now the other way around, so the other person now introduce themselves and their problem. All right, now you have 15 seconds to decide whose problem you want to focus on. So, who's decided which of the 2 problems you want to focus on? Show of hands, please. Come on, guys. Whose problem you want to focus on? Anybody ready? Ready? Okay. Now you have 1 minute to figure out how to solve that problem. Imagine there is no taboos, no regulation, and no budgetary limits. But all you have is 60 seconds. Your time starts now. Go. I'm not joking. Twenty seconds left. And your time is up. Okay, guys, show of hands, please. Who's managed to find a solution to the problem? Come on. 1. Excellent. 2, 3. Any more? All right. Well, we'll call it a win for today. So, A, you've solved the problem. B, even if you haven't, you've still met an interesting stranger to talk to. And just a small plug. We're going to do this, but for 2 days straight at an event called Hack Healthcare, which will take place here in Brussels on the 23rd and 24th of October. And if you want to do more of this, dig into the genuine issues of the Belgian healthcare ecosystem, go down to the grassroots, talk to the patients, talk to the pharma companies, talk to the technology people, the doctors and the nurses. Come join me then, all right? All right, thanks, guys. Thanks so much, guys. You've been fun.
Thank you, Leo.
My absolute pleasure. Thank you.
That. Okay, ladies and gentlemen, we're moving now into a coffee break, and after that break, I'll be leaving you in the capable hands of my colleagues from Euronews, including our health reporters. Euronews' health is just one of a series of policy issues which Euronews is now diving deep into, which I hope you will have noticed online. If you haven't, please do look at our website for more details of our news. Breaking news, analysis, interviews, a whole series of news that we're producing now. And I hope you'll meet Gerardo and Marta, our news reporters, who will be, Gerardo will be running one of the next panels, and Marta will be available to meet in the coffee break as well. So please do make that opportunity to meet with our reporters during the coffee break, and I look forward also to meeting you. Thanks.
so I'm walking in a while.
Hello and a very warm welcome to the first Euronews Health Summit live from Brussels. We've already had a fantastic morning of discussion with lots more to come. Everything this morning can be watched back on YouTube for anyone that missed it. But let's get going. So first up, Commissioner for Health and Food Safety, Stella Kyriakides, stopped by the Euronews office yesterday to chat to Marta Iraola. Let's see what she had to say.
Mrs. Kyriakides, you have been Health Commissioner for the past 5 years, and a lot has happened, including, of course, the COVID-19 pandemic. Looking back, is there a specific moment that stands out to you, that's something that shows the challenges of your role?
A lot has happened, and yes, the COVID-19 pandemic was an unprecedented health crisis. What stands out to me as a moment, an important moment, was the day that through the European vaccine strategy, we managed to deliver vaccines at the same time to all European citizens, to all member states. That moment when I knew that we had managed to reach citizens at the same time, for me, remains a very special moment.
And how did that experience shape your perspective in health policy, specifically EU health policy?
I have always believed, and it was also part of my mandate, that in health we need to work towards equity. We need to work towards all European citizens having access to the same level of health care. And COVID showed us what we can do when we work together, how the strength of solidarity. I believe that with COVID there was a paradigm shift with health. And it showed us that we're stronger when we work together and when we coordinate as member states. So this was the reason that we started putting together the European Health Union.
And of course, the COVID-19 pandemic was a big thing, but it was not the only thing. The Commission also presented the EU's Beating Cancer Plan, one of the main initiatives of your mandate. Would you say this is your biggest achievement, one of your biggest achievements?
The Europe's Beating Cancer Plan is one pillar of the European Health Union. When we look at health, if we look at it holistically, all the pillars of the European Health Union support each other. So Europe's Beating Cancer Plan is supported by the pillar of mental health, because all cancer patients and families need support. It's supported by the pharmaceutical reform, because we need to have access to medicines. But Europe's Beating Cancer Plan, yes, is delivering. We have already changed a great deal of what was available for patients in Europe, but there is a great deal more to do.
There are some of the main topics such as tobacco, alcohol, you mentioned mental health. There's still a lot of work to be done in the next mandate. How do you see this plan evolving in the future?
The next mandate will be challenging in different ways, because now we need to implement what we are putting together as European Health Union. But in order to do that, the main priority needs to be to keep health at the top of the political agenda. If we keep health at the top of the political agenda and use our voices so that we are able to move forward, the European Health Union will be able to deliver what European citizens expect from us.
This work on the European Health Union that you started, now that we've seen the presentation of the new College of Commissioners, we see that health is spread across various portfolios and various commissioners. We have, of course, Mr. Bargelli that will lead the work, but also other topics fall under Labib or under Séjourné. How do you see that working, that spread of health topics?
It's going to work very effectively, because you need to work horizontally either way. Just to give you an example, with Europe's Beating Cancer Plan, we were 12 or 13 commissioners that all inputted into the plan. And this is the same for many of the pillars of the European Health Union. And in order to be able to have policies for health, health needs to be seen horizontally in all policies. So I'm sure that this will be the way forward for the new Commission as well.
And you've also been a big promoter of women's health throughout your own mandate. How do you think the EU can continue to empower women to have control of their own health, especially when we see in areas like reproductive health or access to care?
The reproductive health and women's health, these are basic fundamental rights. And of course, in the area of health, we do see inequalities which are also gender-related. And within the European Union, we see this in different ways. For example, in access to screening programs, we see that there are differences across the member states. So the essence of gender equality and of women's health needs to be central, and women's health needs to also be seen separately, also looking at health professionals. The majority of nurses in the EU are women. And we saw in COVID how important the health professionals were. We clapped for them every night. So gender equality is extremely important in the area of health and something we need to keep promoting.
And now that we've looked back a bit about everything, not everything, most of the things the Commission has touched upon, is there anything you feel you could have done differently, approached differently?
I'm sure that when you look back, you can always think that we could have done things in some areas differently. But what I do believe is what we have achieved is the fact that we have changed the way we look at health, that we have a health union in place, and we need to go on working for the implementation of this. And we must never forget that we started with an unprecedented crisis called COVID-19, which really changed the way that citizens see health and what they expect of us.
And well, finally, I mentioned before that we are seeing now how the new Commission is unveiling. You experienced this, you went through this 5 years ago, through the parliamentary hearing and all the process. Is there any advice you give to your fellow commissioners, to Mr. Bargeli and the others?
I'm sure that they will be equally well prepared and able to engage. It's a very important part of the process, but I would say that the hearing is the first step, because in order to be able to implement policy for the next 5 years, you need to work closely with the European Parliament and the Council. These are part and parcel. In order to be able for the Commission to be able to promote policy, the European Parliament is a very important partner in this process. And it has been for the last 5 years, so this is their first step in building this relationship.
Thank you so much, Mrs. Gay.
Hello, hello, hello there. Good morning. Good morning. Such a lovely audience today here at Sparks. We're broadcasting here in Brussels. I'm delighted to see you all in the audience. I see many familiar faces. My name is Gerardo Fortuna. I'm a journalist here at Euronews, and I'm covering health. It's such an honor to be here this morning. Health data are everywhere, from e-prescriptions to health apps on your phone. And it's been like this for decades, but what was lagging behind was maybe a bit of turning this wealth of health data collected and stored across Europe into something to better prevent, diagnose, also treat diseases, and also, of course, to boost research in this field. So I remember Commission Vice President Margaritis Kinas saying that Europe was sitting on a gold mine when it comes to health data. And then we just heard from outgoing Commissioner Stella Kyriakides. COVID was a paradigm shift. COVID has happened. And this was also created a push for policymakers to increase access to electronic health data. You probably all remember the COVID certificate. That's another example of use of health data. So building up on the success of this initiative, the Commission came up with a proposal to, of course, finally exploit this health data. removing all the existing obstacles to that. The legislative process ended this year, actually, and makers clinched the deal, agreed on a text, and now European health data space is hard to go. Was widely mentioned in the health part of the Draghi report as a huge success of the previous commission, and is considered key to roll up the AI revolution in healthcare, which is supposed to be the next big thing on health. It also comes with some issues related to trust, transparency, and all the traditional caveats that occur when you're dealing, of course, with people's privacy. So today we'll be talking all about that with our guests this morning. So let me introduce them to you and give a warm welcome on stage too, starting with, you don't need a lot of introduction for him, Vytenis Andriukaitis. Vytenis Andriukaitis, MEP and coordinator for the Socialist Parliamentary Group in the Health Committee. Please take a seat, Vytenis. And also former Health Commissioner from 2014 to 2019, if I'm not wrong. And also Special Envoy for WHO. So many things you've done in your career. I also welcome Milana Trussel from Policy Office at the European Patients Forum, with a huge focus in all her career on digital health. And also Jelena Malinina from the Data Director at Eurordis, which is the non-profit organization representing the rare disease community. It's actually there. Sorry, this is my... Yeah, I need to claim my seat. And last, Michele Calabro, director at Euriga, which is the European Reference Network for Regional and Local Health Authorities. Actually, on digital health, you basically work mostly all...
On everything.
Yeah, your lifetime, let's say. So it's lovely to have you all here, a bit different than the normal environment. But let's start with some introductory question. I actually want to know a bit more by Jelena and Milana about the main highlight for them of this European health data space, of this new framework for health data. Starting with Jelena.
If I have to pick one, it would be certainly a common exchange format for electronic health record. We as a community representing people living with rare disease have been waiting for that for a really, really long time. And finally, it's coming. Of course, it will take some time to implement and to put into force. But this is a huge, huge change for all of us, and also for those living with chronic conditions and rare diseases as well. Because you can easily travel with your own medical record anywhere you are and when you're on holiday. So it's a huge step forward.
And you agree with this point?
Yeah, I cannot not agree,
yeah.
Of course. Is it working? Yeah.
Yeah.
Cannot not agree with this. And indeed, for us, really this possibility for the patients to finally have guaranteed access in the electronic formats to the health data is really the most important thing there is in this regulation. And, we travel, we move, we are tourists, we work in different countries. So it's really important that as Europeans move, also the data move with them. And with this access, what is linked is really the portability of those data. So yes.
Yeah, and I'm also turning this into question to Michele. Are you overall happy about the outcome of this lawmaking process?
Well, I think it's excellent that we have a starting point, to be honest. I think, of course, we're talking about a series of data spaces, and the first one, it's on health, which is something that I don't think we would have imagined some years ago, as health has been on the agenda, of course, but maybe not the first one we would have thought about. So for sure, it's an excellent starting point. There's much work to do for implementation, but we cannot not be happy to have it.
And Vytenis, you weren't there in the past legislative mandate, but one of the main problems arising during the negotiations was this trust. So basically, trust issues at public level, because we're talking about sharing data. You had quite no issues, but in your past you've been a target of anti-vaxxer, for instance. They have also trust issues with vaccine preventable diseases and vaccine in general. So there could be a similar problem with acceptance of sharing data for patients, according to you?
Yes and no. Yes and no. First of all, let me tell you, when we are using artificial intelligence, we are thinking about applied statistics. Applied statistics require data. But all of us know that it is very important to have true data, real data, And that doesn't matter who you are, anti-vaxxer or pro-vaxxer. But data is common for all of us. But doesn't matter that we know that data is common, is very important in our lives because we are looking at clock and all of us are using data, different. But this data which is personalized to you, of course, is require a little bit, consciousness and also trust and distrust. We are just staying in so-called post-trust society, Post-trust society, like common picture. It means that we all are in the same boat, keeping in mind that we need to understand much better what does it mean trust. Of course, trust means if you have truly equipped data and truly proposed, ways forward, it can create trust. It means that we need now, as never before, to find our common understanding about trust, about big data, about personalized data, and of course we will face a lot of challenges, no doubt, because it's very common for all of us.
This is offering me a good segue because we did a poll. I think you actually did this poll while reaching this venue, and we asked the people here whether they trust sharing their data now that these new EU rules. We also have the outcomes. And it's actually quite impressive because 85% of people trust the system, which, it's quite impressive. It's not that I don't believe in the European health data space, but it's quite a thing. I don't know, Milana, what do you think about, would you share your data?
So I'm replying as an individual.
Yeah, as an individual.
Okay, not as an EPF representative, but so the short answer is yes, I do fully trust it. The long one is I do, but it's conditional.
Okay.
It's not unconditional, so what we really need to see is how the implementation goes, and one very important point for me is the transparency and also the ethics of the health data access bodies.
Yeah.
So if I see that there is enough transparency, if the data is being shared for purposes that indeed make sense to me and to the society, then I'm still fully, up for sharing my data.
We're going to touch on this point later. Yelena, would you share your data now?
I'm sharing it actually without being asked.
Okay.
And all of us actually do that, otherwise statistics would not exist. So we do share the data. Maybe now there will be a bit more processes when it comes to our data sharing, coming with the European Health Data Space and some other digital rules. But all in all, yes. And also just a small reflection on the poll. People do want to share data until system fails them. So hopefully system will not fail any of us and we will still be encouraged to share the data.
That's quite of a prediction. Michele, would you share your data? You're already doing it.
Yes, I'm also doing it already. I think everybody is. And I think connecting to what Yelena was saying, it was great to also see that in the new Commission letter, there's a high focus on cybersecurity, for instance, which is, I think, essential for ensuring that nothing wrong will happen in the realm of course, what's possible, and will be, of course, equally important to then give people the chance to know what data is used for, have a chance to understand how they can control, look at it, and so on.
You saw earlier my colleague Marta Raola interviewing the Health Commissioner. She had also something to say on the European data space. Let's hear from her.
The other main topic in the past couple of years have been digitalization. Now we have the European Health Data Space that will start implementation. What should be the next step? Also, when we talk about different tools, we talk about AI, what is the potential there for the EU?
Using the full potential of health data for citizens and for patients. There is a great deal that we can do if we harness the potential of health data. And both in access, but also in the rights of patients. And we saw how we were able to digitalize the COVID certificate and how we were able to open up economies and societies. So moving forward with the European health data space is going to be important for patients, for access, but also for research and innovation.
So we just heard from Stella Kyriakides. Yelena, you think that this was enough to untap the potential of health data? Because you were mentioning this before too.
It's the beginning. I think it's the first, well, not really the first, there were some steps before that, but this is a significant change simply because now we will have a common agreement between the member states, which was not present before, on certain things, on how to untap actually this huge potential of data. And specifically for rare disease community, we do have high hopes for faster diagnosis, potentially for new treatments as well, because for the moment only 6% of the ones living with rare disease do have treatment. So imagine 94% of people just live with the condition. So there is a huge, huge need for new discoveries, and we hope that they will happen with new quality data, actually better quality data and better data availability. And of course, many new tools such as AI-powered medical devices might come and also significantly help people living with rare disease to manage their condition and to live a fulfilling life.
And also, Milana, there's this fancy word that sometimes in this panel pop up, which is digital literacy. But it's true that for the health data space, it's all about patient knowing their rights. Yes. So what can be done in order to lead the patient in having choices about how to share their data?
It's actually a very good question, because this issue of how patients will actually know what's happening with the EHDS has not really been discussed, and also in the Parliament it has been a bit more than the Council, but it was really, really like low-key. So one thing that, for example, as a patient organization we are doing is we are creating some educational materials for the patients. They will be in their language, they will be translated in many languages, and we will going to explain what is European Health Data Space, what are the new rights or enhanced rights that these patients will have, of all of patients, but also how they can exercise those rights, and if there are any exemptions, for example. And if I can just add one short thing, is we really hope that we'll have the help of member states and regional authorities, of course, to share this, because if it just stays, you know, at the EU level, in the EU bubble, it's just not useful.
And Vitalis, you're a policymaker. I mean, you're back in Brussels. I mean, you were doing this before, even during in these 5 years you've been away from Brussels. So there's also an issue not only when it comes to patients, but also how to educate healthcare workers. I mean, you've been a surgeon as well. So how this education to sharing data and using data can be spread across the entire population, even including healthcare professionals and hospital staff. What's your take on that?
You know, not only including healthcare professionals, we need to think about inclusion of all, you know, health for all in all political sectors. Very nice slogan. Now we need to ask how can we include all into those health political issues. Without leaving no one behind is a main slogan. Leaving no one behind, educating, you know, equipping, you know, inspiring, explaining, and so on, so on. You have no chance to exclude patient organizations, individuals, local communities, national parliaments, national governments, also healthcare professionals from different ones, because it's only one way. Otherwise, you can see a lot of challenges. Look, how we have today picture in social bubbles, in social networks. In social, you can find a lot of theories, conspiracy theories, a lot of fears, a lot of misinformation, disinformation. Now, in our, I'd like to say, in our digital society, you see a lot of challenges which are done by digital tools. It means we need to ask about digital education. Why you are doing that? Why you are allowing spread some stupid ideas, conspiracy theories, fears, and all misinformation, damaging yourself. Because everyone who is doing it is damaging yourself. It's not.
There's the risk of having this misinformation.
It means that we need to have a literate education in very broad sense. Very broad sense.
This could also affect the sharing, how people think of data, of sharing data, this kind of misinformation, you think?
Yes, absolutely. Let's keep in mind, we need trust, we need educate, we need equipped, we need protect, and we need secure, and need provide. If we can understand such holistic approach, that we need to provide to people what? Real treatment, especially in areas where this is 32 million are suffering, patients and suffering now in the EU. 100 more millions are involved around those patients, It means that now it's a message is big data require big actors, but those big actors are all of us, because we need to achieve something more positive. And it means that the sharing of data, guaranteeing trust, guaranteeing protection of data, guaranteeing access to data. It's for all of us. It's common public good. Speaking in health.
Indeed. And Michele, you're working with regions. The same education, the same digital literacy. It's also something that should affect also local authorities. What could be also the role of regions in implementing, and also in working with patients and patient community?
Well, first of all, I think, about 2/3 of European countries have some degree of competence in healthcare at regional and local level. So I think for the general implementation of the health data space, as with every other policies, I think it's necessary to work with them. And besides this, talking about, developing skills, developing literacy, understanding what's happening on the ground, that's equally important. As Milano was saying, I think there is a great potential from the local and regional level in really knowing what's happening in their communities. It's indeed something that, creating trust, creating education, creating literacy, working with patient organizations can be done at European level. I think we're doing it in this panel, but at the same time, the individuals will need to get it at the local level. And for doing this, it's necessary to indeed build on existing cooperation that there are, from the regional and local dimensions of patient organizations in different diseases and everything. I think there's a particular also understanding and increased trust where you work with the closer level of governments, I believe. And most importantly, again, it cannot just be, an information leaflet that come raining down from the top. It needs to be done together with the communities.
But this was something that Jelena said before. So the main thing is that now you have something for all the member states. But is there a risk to have a fragmentation at regional level then?
In principle, the HDS, it's a framework that it's supposed to level the thing up. So, of course, we now know that there is fragmentation in a way. There has been countries and regions within countries that have managed to move ahead because, working on data, working on digital transformation, it's not something that started with the EHDS. So people have moved already. Now the important thing will be to really try to work on the level up dimension rather than kind of just copy-paste what's been done already. I think that's important, looking at what's happening, but I think it's important to build also the knowledge and awareness also at the policy-making level, at regional and local level, because there has to be an understanding of what the EHDS will be, how they need to implement it, what type of resources, and which type of partnership that will have to be implemented to work on it. So there is a risk of fragmentation, of course. It's not going to be easy, but there's also richness to it, I think.
So now we all love the European health data space, particularly people in the audience. Apparently they have a huge trust in these new rules, but I'm trying to spice it a bit up. Is there anything missing, according to you, in these new rules, starting from Jelena maybe, that you would have preferred seeing in the final outcome of the negotiation?
That's a very good question. I think what is missing, and there is still room actually to fill that missing space, could be specified in implementing acts, which are coming in the next 2 years. When you read the law, and the ones who read it, it kind of answers to a lot of questions. It sets out the general framework, but when it comes to, I'm just imagining myself in the role of a member state and working in the ministry and getting that, and for some, I wouldn't know how to do that exactly. Yeah. So this pathway is currently missing, and I really, really hope that the legislators will come up with very comprehensive implementing acts in the next couple of years in order to explain the process and also work together with the member states and other stakeholders to really understand how to turn this theory into practice, because for now it's just a theory.
I mean, Vitenis, as former health commissioner, knows that the devil is in the implementing acts. But Milana, you have some thoughts on this?
Yeah, I fully agree with what Jelena said also, because we have to really avoid making it a new GDPR that's not implemented, it's not harmonized in all member states. But another thing that I would mention is that the cooperation with the stakeholders, especially the patient organizations, is not institutionalized, and we really wanted that to be in the regulation. So what the regulation says now is that all of the governance bodies of the EHDS shall cooperate with the stakeholders, but we don't know how that will look like. We don't know, how much feedback they'll actually take from us. Will it be actually taken into account? And what we proposed was to take the EMAS example, where they have the patient representative on the board. It's not perfect, but it works very well. So this is something that's missing for us.
That's a good point. Vitalis, you were mentioning before some disparities. Do you think that there might be disparities when it comes to access to this technology? Because I mean, okay, we have a lot of data from our phones. You mentioned it before. But there are also some maybe medical devices that are not super easy to get.
I see a lot of disparities. First of all, some disparities are enshrined in the Lisbon Treaty.
Yeah.
Because we have 27 different member state systems, 27 different medicine markets, no one single market, 27 different regulations, 27 different languages, 27 different understandings, 27 different healthcare systems who are not communicating to each other. Cross-border healthcare directive is only on the paper. In real life, is ongoing. If you can ask myself, for example, are you capable to receive e-prescription from your home country, from Finland, and go and buy in the pharmacy using e-prescription? Or second issue, you are a parent, you are traveling from one country to another, working with some companies, and you have family together with you. You are decided to vaccinate your child, you are going to member states, they can telling you, look, in our vaccination calendar, it's too early to vaccinate your child. In another country, oh, no, it's too late. And we have 27 different vaccination calendars, a lot of differences, and it is great distrust to people. And we have no chance to have one vaccination electronic card to every child to know how can you behave, how can you achieve. Why? Because 27 different regulations. It means the same speaking about healthcare situation with rare diseases. Look, we propose to establish European reference network. It's so powerful infrastructure, so excellent opportunity. So excellent opportunity to solve a lot of problems. Can you imagine, you remember Beatles' song, Imagine. Imagine EU without national obstacles. Imagine. And imagine that you can see European reference networks as well-functioning, digitally equipped, well data protected, a well data managed system. It can help you treat your child. Doesn't matter you are in Cyprus or in Finland. And then imagine that you have good pan-European infrastructure which can help you really see European health data space in reality. Because we need to think about ecosystems, about infrastructure. Imagine that you have opportunity to invite all researchers and industries to do with some treatments, innovative treatments, clinical trials, using such pan-European, European reference networks, infrastructure, and IT tools, and artificial intelligence. It would be excellent to solve a lot of problems. But you have a lot of obstacles because 27 different countries, they have no chance to understand that we need now to go forward in this direction.
Indeed, this is the main issue at the EU level that basically is not a competence. Health, of course. You were mentioning the what it's called in jargon primary use of data, so health records and so on. But the most controversial issue during the discussion among lawmakers was the so-called secondary use, so basically data registered for use and used by third parties for other purposes. There was a novelty from the parliament. There was this opt-out clause. I think Milan and Yelena had two different visions on opt-out. So let's create some clash. No, I'm joking. What do you think about opt-out? It's something that was particularly dear for you, of course. Can you explain a bit what it is, and also maybe it could also be difficult to? It's a bit the same question I asked before. To communicate to patients how to use this right of opting out.
Starting from how difficult it is, we don't know, because it will be up to the member states to actually include it in the electronic health records. So we still don't know how this is going to work. But we really indeed pushed for this to do the inclusion of the opt-out in the regulation, because it was not there with the proposal. And what is it? It's really the possibility for the patients and citizens to opt out from sharing the data for the secondary use if they do not wish so. But of course, there are some exceptions, such as for public health purposes, pharmacovigilance, regulatory purposes, etc. And indeed, we really pushed for it, because this is what we found that our community really thought was needed. This was missing from there. But on the one hand, you have to enhance the trust among the community. On the other, you still have to provide this opt-out. So if people still do not feel like they want to share the data, they should still have the opportunity to do so. However, we're against the opt-in. I know that in some cases it might look like the same thing, but what we heard from the patient community is that they don't want to be bothered to have to go on there and to have to say that they want to share the data.
Just explain to our... Like, I mean, who's watching this opt-in, it's basically...
It's proactively saying, I want to share my data. So I would have to go on my electronic health record and have to do this thing. While the opt-out assumes that you want to share your data, and then if you don't feel like, then you can go and opt out from this data sharing. So it does take this action, but you're still sharing the data if you don't opt. But if patients don't know that this exists, then they're just sharing the data without knowing. So the opt-out is great, we're happy it's there, but it's kind of useless if you don't explain to the patients that there is this opportunity. And the only way for the patients and citizens not to opt out is to ensure that they trust the data sharing ecosystem.
Yelena, opt-in, opt-out. Why you think that Milana is wrong?
I don't think she's wrong, actually. The reason why we might have had a bit divergent view on this question is because for me, opt-in and opt-out is like melon and watermelon, to be honest. So it's different, but it's kind of the same. So it depends what you like. So it's still around consent. So it's just about when the point of consent is coming. Are you proactively asked to consent to share your data, or you're given an opportunity to opt out from the system, to withdraw yourself from that system? It is still about consent. And there is a little bit of danger. Please don't take me wrong. I'm a really big data protection fan.
You're super cautious.
Yes, but I think data privacy is super important. But consent sometimes is really misused, and it becomes like a box-ticking exercise. You have been asked consent for your cookies, right? When you go on browsing on the internet, you consent so many times per day, but was this consent meaningful? Do you actually know what happens with your data? And unfortunately, the answer most likely will be no. So we don't want to be in the situation that we use consent as something just, to cover up some practices, saying, hey, we thought about you as a patient and as an individual, we provided you with consent option. There is much more than consent. So there are other safeguards. There is also, and consent might be just an element of a trust to the system, and sometimes it will work, sometimes it will not work. And there is need to actually put an emphasis on the entire security and safety of the system rather than just purely relying on the consent. That's why our views were not maybe so strong specifically for opt-out or opt-in. It's a really relevant option. It should be given to a person, but it's not the center of it. Thank you.
We have another clip from another MEP to watch, apart from the tennis, clearly, Andras Kulia.
During the last few years, we focused to health due to the pandemic. However, with an increasing number of NCDs, an aging population, climate change, we need to keep the health as a top priority, and we need to ensure the dedicated budget on health, or even raise the budget, because it is how we can make our healthcare systems more resilient, more stronger, and also the European Union stronger economically and socially.
Yeah, that was my arm indeed, the one carrying the mic. It's actually a question to Michele and Vytenis. So it was something that Kyriakides as well said before, so basically keeping high health as a priority. But there's this issue of budget. There was this exceptional line of budget, EU for Health. Even in the Commission, they're not super sure this is going to be repeated again. Probably a standalone one. So what do you think about having an and also how this could be used to implement the HDS?
Yes. First of all, once again, let me ask 27 member states what they are thinking about European budget. As you know, European budget figures were enshrined in the Lisbon Treaty. It's 1% of GDP. Can you imagine it was done in 1992? And then it continues till now. Can you imagine to go forward with such small European Union budget? Ridiculous. And nobody is talking about. If you compare now budgets of national government, member states, with budget of EU, you can see that it's obsolete. 1% of GDP is obsolete. Now, Draghi proposed to invest every year 800 billion euros.
I was about to ask you if you read the Draghi's report. I didn't. I mean, not entirely.
But look, it means that EU should have debt. Otherwise, you have no chance to attract money. But in Lisbon Treaty, strongly, EU budget should be without debt. You see strange paradox. We all speaking about big, issues, not going directly to the point. Because the point is, when I speak about investments, point is EU budget. EU's budget is a very big one. And of course we need much more investment into health care, into health education, in promotion. Promotion is better than care, all knows about. But how many money are putting all member states into promotion? How many? From 2 to 3%, not more. And we are speaking about promotion is better than cure. Why we are lying each other? Don't lie. Don't say we need to revise our budgetary capacities, our investment tools. We need to think about our own EU resources if we need to address those issues related to our promises to deliver social Europe to everyone. Otherwise, and of course, please keep in mind also, when Stella Kyriakidis proposed, or Commission proposed, budget for EU for health, first proposal was 10.3 billion euros, yes, very small one. But Council of Heads of States and Governments decided to cut to 1.2 billion. Yeah. Those guys which we are calling heads of states,
and indeed,
they decided to cut, and only after pressing from European Parliament, once again from Commission, now we have 5.3 billion. Yeah. It is a very small amount.
And Michele, you actually worked on the EU for Health quite a lot. How could it work in order to implement the European data space? And also if you think that it should be continued also in the next budget?
I mean, it's called EU for Health now, but it was called Health Program before, so it always existed, I think. And actually, it is an instrument that, if I'm not mistaken, in the specific objectives of the regulation underpinning the EU for Health, the implementation of EU health policies, it's one of the key targets. So it's the instrument made for that. And for instance, I can bring indeed the example of the many joint actions, which are collaborative projects between member states' authorities that are looking at issues very much related to implementation. For instance, the joint action called TEDAS2 will be looking at the implementing acts, so trying to fill those gaps, those missing pieces of the puzzle. So I think the money is there, it should stay there. Of course, we should always aim for something bigger, as we had a good starting point, and I think it's also our collective duty to keep advocating for that. I think that's the most important thing. Now, I think beside EU for Health, I think in the new mandate will be very important to also even work more on the connection between the different funding programs. Horizon Europe, indeed EU for Health, but also the funding for cohesion and so on.
Integrating a bit.
Exactly, better integrating, because there's a lot of investment that already gone into kicking off initiatives on digital transformation, HDS. So we need to build on that, also to use it in a better way, more efficient, I would say.
And we move to our last topic. So what could come next once we're going to have this framework? Actually, in the Draghi report, this was mentioned quite often. As I said, I haven't read the whole Draghi report. I think none of us did it. But, you have to make choices in life. Either you read the Draghi report or The Lord of the Rings or something like that. But there was a huge push on health data space as the first step for the uptake of artificial intelligence. I know that Milana, but also Jena, worked a lot on the artificial intelligence. So how could the EHDS be introducing this new revolution, actually?
I think that the most important role for the EHDS when it comes to AI is really the data that we have in these records. And what we really hope is that the data in the EHDS will be more representative and less biased than what we have now, what we're inputting at the moment in the AI tools. So yeah, that's for me the biggest role really that it will have.
Jelena, do you think that there's something missing on AI at regulatory level that maybe we need artificial intelligence, whatever, for health?
I think you answered, actually. We need some specifications for AI in health specifically. Yes, there is AI Act, there is medical devices regulation, in vitro diagnostic regulation, but also keep in mind when everybody refers to MDR or IVDR as a solution, they're quite old already, so they're still not being implemented, but they're not exactly up to date with whatever is happening now or might happen in the future. So there is a need for a more comprehensive framework. There is also a need for some questions which are very, very specific to health. For instance, doctor and patient relationship, and when the AI intervenes into that relationship, how do we view it from the legal point of view, from doctor and patient rights of view as well? These specific questions are not answered anywhere yet, and they're very much debatable. There is a whole new shift which has to happen from traditional healthcare and from traditional healthcare ethics to a different format, I guess, to big data era. So we need to make that shift, and yeah, we need some kind of legal instruments as well to answer to these questions. So this is missing for the moment.
And we have a last clip from actually the youngest MEP in this mandate, Green MEP Lena Schilling.
You know, we shouted as climate activists, there is no future on a dead planet. And at the same time, we have to realize there can't be healthy life on a sick planet. So what we have to do is to fight for environmental justice, for justice in the healthcare system, and also for social justice, and connect all these fights.
Yeah, this clip is to introduce also the next part of our show. But what do you think, Vytenis, about, you know, what's your take on the future of health in this mandate? You're going to be a key figure as a lawmaker in the European Parliament.
I can ask you to support me to be very active on topic of health. First of all, I am ready to propose second building block of the European Health Union, because Ursula von der Leyen proposed first building block, and just Stella Kyriakidis talked about first building block. You know, 5 programs: crisis preparedness, pharmaceutical strategy, European cancer plan, mental health strategy, and long-term care strategy. 5. Now we need next building block, next 5. First of all, of course, healthcare systems resilience and healthcare workforce crisis, because it can affect all of us, including artificial intelligence, including all.
I didn't ask you what's your take on artificial intelligence.
And you know, speaking about artificial intelligence, we need to propose second building block, building European reference networks and ecosystem, and speaking about health data space, and also including artificial intelligence capacities. To solve problems here, we need to build ecosystem which can, based on European reference networks, also be incorporating artificial intelligence centers, computing centers, and of course also dealing with one genomic, you know, one genomic project, health data. It can help us really to also to guarantee to our European companies to be more innovative using such infrastructure and producing new innovative treatments, personalized medicine, and so on. It will be second one big block. Third big block is, of course, the IMR, immunization program, and new vaccines. We need to keep eyes in those both challenges. Fourth would be very clear, prevention strategy. It should include prevention, protection, and promotion of health, and also participation. And fifth, cardiovascular strategy, fighting against premature, big number of premature deaths. It would be good to build second building block of the European Health Union, and then go into treaty changes.
And then go to treaty changes indeed. Michele, what are your expectations on the next Monday?
I mean, just hoping, of course, that health will stay as high in the agenda as possible, hopefully also without a crisis to connect it to. But at the same time...
Your team keeping it as a priority.
Keeping it as a priority, but also doing a little bit better work in connecting it with other areas of policies that have a big impact on health. We've been talking about health in all policies for health for quite some time. I think it's now important to really act on it, as also I believe, you know, the MEP was rightfully mentioning. I think that's going to be, that's one of the questions that I would also ask to the next commissioner designate, to be honest.
And also a quick thought from Yelena as well on her expectation.
I second Michele. I think we are really hoping for health not to be an ugly brother, which receives nothing from their parents in terms of money. So it has to stay the priority, and we don't have to have any kind of crisis, another pandemic, to realize that this is actually the foundation for anything else. Economy, market, whatever you want. Without health, it would not happen. So this should be the focus.
It's a bit the risk, you know, we had this bonanza during this mandate, and now...
We need to implement.
Yeah. I don't know if you want to add something. Mina.
Cannot but agree on this, and just maybe what we would also expect from the new mandate, both from the Parliament and the Commission. We had quite a good relationship in this past mandate, but I think this patient involvement needs to be even more there, because we are the final recipients of our health policies, and if we are not involved and if our voice is not heard, then it's not really patient or person-centered at all.
Yeah, I'm afraid that our time is over. I have to stop here because we come to the end of this panel. Thank you so much to our guests. And ladies and gentlemen, I have a round of applause for Michele Calabro, Yelena Malinina, Milana Tutzer, and Vytenis Andriukaitis. Thanks again for being with us. I hope you actually enjoyed this. I haven't asked you if you read the Draghi report. This could be the next poll, to be fair. Like
I read The Lord of the Rings.
Yeah, but just the health part.
Yeah, the health part, of course.
Although it was quite focused on pharmaceutical.
I mean...
You're Italian, you don't want to comment. You don't want to say...
I don't want to say anything bad about Draghi.
Yeah, exactly.
No, but it's important to, you know, make sure that healthcare it's looked at from the whole health systems dimension, of course. Okay. So I think that's an important bit anyway.
Thanks, Michele. Now it's the moment for the big question.
This is a new era for Europeans, an era of interconnection, where geopolitics and economy are inseparable.
We can reach our climate targets. All the countries should believe that this is achievable.
Innovation meets disruption, and uncertainty meets never-ending opportunities. Get the latest news and analysis on Europe's economy, business, and markets.
The most brilliant minds in business. Vulnerability is a strength, not a weakness.
The new industries that result from what we're doing will be better for people.
Will be growing, sustainable.
And that's just the nature of the business.
From the Eurozone's diverse economies to its emerging startups.
Station F is the world's biggest startup campus based in central Paris.
We discuss what makes the world entrepreneurs tick and see the bigger picture of what's going on in the world of business.
AI is not your friend.
I would say Europe could do better. I would say the world could do better.
Welcome to The Big Question, the series from Euronews, which seeks to answer some of the biggest topics on the business agenda.
See the big picture.
Hello and welcome to a very special live edition of The Big Question here in Brussels. Today I am joined by, and please welcome to the stage, Nedim Pipic, Senior Vice President and Global Head for Mental Health from Boehringer Ingelheim. Thanks for joining. So, thanks for joining me today. We'll dive straight in. So, we know the world is talking a lot more about mental health these days, but how big is the actual problem?
Wow, where to start? First of all, thank you for having me, but this is a big topic to talk about because it is a big problem and there's a huge unmet need to be addressed in mental health. Let's start with the size of the problem. If you think about it, 1 in 8 people at the moment are suffering from a serious mental health condition. Sadly, 1 of 2 people in this room are gonna be affected by a mental illness in the course of their lifetime, statistically. So that already raises a high sense of urgency of saying, is that something we could address better? On top of that, when you look at the consequences, serious mental illnesses are the leading cause of disability worldwide. And it affects those who suffer from it in a way where then 10 to 20 years of a lifetime is cut compared to the general population. Maybe a concrete example, schizophrenia, we don't often talk about it, but it's a disease which affects 1 in 300.
Wow.
24 million people, and also has the highest societal cost per patient of all the mental illnesses. So I think just maybe to frame that a little bit, the other issue contributing to the problem is lack of access. Already before COVID, many who would have liked to seek mental health care had issues getting effective care, getting solid treatments, and that gap has only increased post-COVID. And actually 70% of those in Europe who seek it lack access to mental health care. So now imagine if we had that same issue with cancer care, probably we would already have a national public health emergency.
Yeah, absolutely. And so do you think the problem is growing, or are we maybe just getting better at diagnosing mental health problems, or just even talking about it?
I think it's both. It's definitely growing. Prevalences are increasing. When you look at the after effects of COVID, when you look at the climate crisis, cost of living, the war crisis, it is taking a toll on all of our mental health in general. At the same time, COVID did bring mental health well-being, anxiety, stress to the forefront, so it's become more visible. Also that the prevalence there is rising by 25% has become more visible. However, while that is being more talked about, the area of serious mental illnesses, which is so large, continues to be left behind. So topics around major depressive disorder, schizophrenia, PTSD, it's much harder to talk about that.
Yeah.
And this is where stigma comes in. So stigma is this huge barrier around serious mental illnesses, the misconceptions in society, which we all sometimes play not always the most positive part in. The misconceptions we have about those affected with serious mental illnesses, that's what's causing stigma. That's what's causing those who actually need help to be afraid to seek help, to talk openly about it, to talk to their loved ones, to seek treatment, right? So this is where a lot more education needs to be done to make it, to break it down, and to allow those with serious mental illnesses to actually live the lives that they really want to live.
And you mentioned just then, about schizophrenia. I had no idea it was kind of so prevalent. And do you think stigma is a really big problem with that, and particularly maybe the how people perceive it?
Yeah. Schizophrenia is a key example when you look at movies in the last 10 years and how it was also misrepresented in the media and how it might have affected those who actually have to live through it every day. Yeah. I think that's an issue, but it's not just schizophrenia, right? So people don't dare to talk about PTSD, which will become and is becoming such a huge problem with the war crisis we have around the world. And the same is true with major depressive disorders. It's just so hard to say, this is a burden on me, can you please help me? So a lot more to be done there.
Yeah, absolutely. And going back to, you compared serious mental health issues with cancer and kind of the approach. So let's touch upon that a little bit more. Not necessarily cancer, but thinking about physical illness versus mental illness, and you know, that difference in the level of research and funding and access to support. Can you maybe compare two issues that maybe affect people in similar ways, and how that funding is different?
So maybe to just start with the statement that in both areas, both the state healthcare system area, just as much in the industry area of research and development, there's a clear underinvestments and underrepresentation of mental health. I think we heard it in the last panel. Healthcare sometimes seems like the ugly brother, but mental health care within healthcare is maybe then the ugly child that nobody wants to address or talk about, which is shocking. If you look at the healthcare systems, while on the one hand, the amount of those who need support for mental health issues is increasing, the healthcare systems are not adequately prioritizing it. In Europe, less than 2% of the healthcare budgets is actually being used to deliver mental health care. Again, comparing to cancer care, this is where 6% of the healthcare budget spending is being used to improve cancer care. So definitely a topic to be aware of. Thinking about the industry and the research and development, there's a clear lack of innovation. For many of you who might have followed it, well, following is hard because there was not much in terms of new treatments. It's a very big unmet need, especially for serious mental illnesses. Very few new treatments, for example, in schizophrenia in the last 30 years, right? So some progress has been made, but still a huge gap to be closed.
Yeah, and you mentioned that, you know, less than 2% of healthcare budgets are dedicated to mental health. What do you think it should be in order to tackle the problem?
So maybe to focus on two things which are so connected. We probably all see it, and by the way, coming from the UN General Assembly last week, the issues are very similar in developed or developing countries. The size of it might be different, but there's a clear under-resourcing in the delivery of mental health care services. There's a lack of personnel on the psychiatrist side, so healthcare professionals, nurses, psychologists. There's maybe new people starting, but also stopping, and there's no backfill coming in. So it's almost like a vicious circle. So this under-resourcing is something that needs to be addressed right away. And that combined with, you also need to deliver on a care pathway. So you need to address the patient journey. Care pathways in mental health are broken. We have issues with diagnosis, comes too late, lack of treatment or lack of effective treatment, or people don't dare to ask for it.
Yeah.
And rehabilitation and addressing relapses is also not working. So addressing the broken care pathways and the under-resourcing are the 2 points which could definitely make a difference.
Yeah. And so, I mean, I'm sure everyone in this audience would agree that, you know, we all deserve a happy and healthy life, but maybe that's not always necessarily how the world works. And so, you know, is there a business case? I guess the big question here is, can we afford not to solve the mental health crisis?
For me, it's a rhetoric question. No, we cannot. We cannot afford it. We cannot stand still. I hope everybody agrees this is good mental health is truly essential to a well-functioning society. So some action needs to be taken now. Maybe to look at it from a global perspective, mental health illnesses and the conditions that are challenging so many around the world have an economy burden globally of around $2.5 trillion US. That is going to almost triple by 2030 to $6 trillion US. And I know it sounds like a big number, but to put it into perspective, 6 trillion, that's larger than the size of Germany's GDP. That's 1/3 of China's economy. So sometimes, and this is why I get goosebumps when I talk about it, because why are we not addressing that, right? And maybe as a takeaway, the investments in mental health is not just in that area. If we do that well, it's an investment in the society, it's an investment in our economy, and it's also an investment for all those affected and their loved ones, the caregivers, so all the individuals could benefit from that.
Yeah. And why do you think currently mental health is so underfunded?
So maybe on the why, maybe let me connect it to the actions to be taken. right? So there's three areas. Policy making, as we already mentioned, the needed investments to drive the change. And the third one, definitely still a lot of education that needs to be done. So maybe that also explains the why. It's the lack of those. Like in the last session, also around healthcare, and I hope more will happen. Let's start with the first one on the policy making, policy shaping side. There's no better time than now to really act from a government perspective, from a national perspective, with following a comprehensive mental health care plan that has now been lined out by the EU Commission, following a comprehensive mental health care plan and the 2030 UN Sustainable Development Goals, right, that are also lined up at the UN level, but the governments need to commit. It's always nice to have a piece of paper, but what are you going to do it nationally? I do have to say, it's important to have it at a UN level, but it will be worth nothing if nationally it is not being addressed properly. Investment. So investment requiring change. I do want to again re-stress, that we are talking about a domestic gap of around $200 billion that would be needed to close, that was the estimation in the latest research, to really close this underinvestments, at least to a decent level. So again, focus is key because we will not get to 200 billion now.
Yep.
Lack of resources to address that, the under-resourcing of healthcare professionals, and really, again, to address the patient journey, to help repair those care pathways, to truly help those who live the experience. Lastly, on the education side, we need to create more acceptance, a better understanding for all of the people living with the experience of having a serious mental illness. And that actually means putting their lived experience at the center of everything we do. Share real-life stories.
Yeah.
Use the World Mental Health Day on October 10th to actually expose those stories. So many would like to share it. We need to let them. That will create understanding, acceptance, empathy, and also hopefully help them lead the lives that they want, get jobs, keep their jobs. So I think a lot of topics that we can do better towards a more inclusive society in this case.
Yeah, and just on that point of keeping jobs, there was a Eurobarometer survey last year, and 53% of respondents said that financial security is a contributing factor to good mental health. And there are statistics that suggest that following diagnosis of schizophrenia, for example, rates of employment and education dropped 12%, which is a shocking statistic. What needs to be done to keep people happy, healthy, and employed?
Maybe then let me pick up the point of the lack of innovation, because as you mentioned, schizophrenia is a very good example. There's just been almost no new therapies in the last 20 to 30 years, and that's an issue. So how do you help those in need to actually be able to function better in daily life, right? How do you make sure that they can do everyday activities? Because on that example, that's exactly what was mentioned, to go shopping, to be able to cook, to be able to follow on with their education, and keep and execute on a job on a daily basis. And I think that innovation part is so crucial, of also getting new treatments. Working at a pharmaceutical company, obviously that's something we need and are committed to. But also, to be honest, the lack of innovation was also driven by it's very hard to succeed in mental health when it comes to clinical development, which is harder to execute. Endpoints are not always clear, so the probability of success for new treatments is lower than in many of the other therapeutic areas. So this is something that we all need to commit to, including us at Boehringer, to make sure that we can deliver on that, but it's also something that will take time. And we will take a lot of learnings along the way until we truly have something that will help patients out there.
Yeah, absolutely. And on that note, unfortunately, I would love to sit and chat to you all day, but it's all we have time for. But thank you so much for joining me today on this live episode of The Big Question. And thank you so much for your fascinating insights.
Thank you, Anna.
Let him pitch, everyone. Thank you very much. And with that, we've come to the end of the very first Euronews Health Summit. Thank you all who have joined us today in person and online. We've got plenty more coming up later this year, so if you'd like to come to more of our summits. We've got the Euronews Green Summit on the 19th of November and our Tech Summit on December 4th. Hope to see you all there. very much.